Another, sir?
Yeah, please, sir, please.
Yeah. Good evening. I heartily welcome one and all for this World Heart Day virtual program. All delegates who have joined virtually from whichever place to learn from the esteemed faculty. I also welcome all our RSSD members from all over the country and other collaborators for various organizations who have participated in today's mega event of Defeat Diabetes campaign and creating awareness on diabetes, and an official attempt for Asia Book of Records for conducting highest number of blood sugar tests done, one nation, one day, 1 million blood sugar tests. On this occasion, I welcome our guest of honor, Dr. P.S. Shankar, Professor Emeritus RGHS Bangalore. I welcome Dr. Shivraj Alsetti, President MESART, and Dr. Murugesh Pastapur and his team. I welcome our guest of honor, Dr. Muruganathan, past Governor ACP India Chapter, past Dean ICP, and past National President of API, who needs no introduction. I also welcome our guest faculty and today's speaker, Professor Dr. Upendra Kaul, a BC Roy awardee, a Padma Shri awardee, Chairman Cardiology and Dean Academics and Medical Research Center, Batra Hospital, Delhi, Adjunct Professor, Jamia Ahmedabad University, Delhi, and MIT University, Noida, Editor-in-Chief, Asia Interventions, and also Joint Editor of Euro Interventions, a great teacher in field of cardiology in the country. I also welcome Professor Dr. Nagaraj Desai, today's Chief Moderator, Director, Namana Medical Center, Bangalore, and Adjunct Professor, JSS Academy of Higher Education and Research, Mysore, former HOD and Director, Department of Cardiology, Ramaya Medical College, Bangalore, with many publications, both nationally and internationally, participated in several international trials, a great academician, mentor, teacher, par excellence, loved by all the faculty. I also welcome our own guest faculty and today's panelist, Dr. Satyavan Sharma, Chief Cardiologist from Mumbai, Bombay Hospital, Mumbai, past President of CSI and past President of SARC, a former Professor and Head Department of Cardiology, TN Medical College and Nair Hospital, Mumbai. He has received many fellowships like FAMS, FSCC, FSCI, and FESC, and many others. A great teacher and a reputed cardiologist of the country with innumerable publications in international and national peer-reviewed journal, and written many chapters in textbook of medicine and cardiology. A great teacher, a researcher, and a scholar. I also welcome our panelist, Dr. Vivek Javdi, Chief Cardiothoracic Surgeon from Bangalore, with vast clinical and academic experience with various academic positions held in the country, received many awards like BC Roy, Karnataka Rajyotsav Award, and Harvard Medical International Lifetime Achievement Award. With many publications, both national and international, he has performed the first Indian beating heart bypass surgery, first minimal invasive bypass surgery, and the first awake open heart cardiac surgery. A dynamic personality, internationally renowned surgeon, training many youngsters across the globe. On this occasion, I salute the COVID-19 healthcare workers for rendering their untired service to COVID-19 patients in spite of so many hurdles in the past, anticipating the third wave. Let us not waste the time by reading the CV profile, which runs in pages. Let us utilize time by hearing and exchange of knowledge with them in their respective specialty. As I can see, more than 100 delegates who are registered from many states making a national event. The advantage of virtual meeting, which COVID-19 pandemic has taught a new normal life, that speaks how powerful the speakers are there in their specialty. Now we have a formal virtual inauguration.
Shubham Kurutvam Kalyanam Arogyam Dhanasam. Shubham Kurutvam Kalyanam Arogyam Dhanasampada. Shatrubuddhi Vinashaya Deepajyotir Namostute Deepajyotir Namostute Shubham Kurutvam Kalyanam Arogyam Dhanasampada. Deepa दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीप
Thank you. We are virtually honoring all our guest faculty for their tremendous contribution to their work done in the field of cardiology in the country. The citations and the medals will be delivered to their respective places for all the speakers, Dr. Upendra Kaul, Dr. Satyavan Sharma, Dr. Vivek Javdi, and Dr. Nagaraj Desai. So on this occasion, I request Dr. P.S. Shankar and Dr. Muruganathan to do the honors virtually only. Now we have a small video on World Heart Day to be played as a mark of World Heart Day celebration.
All over the world, hearts are hearting. Some places have it all over the world, hearts are hearting. Hearts are hearting. Some places have it worse than others. What can we do to connect our hearts? It starts with how we can use heart to make healthy choices. But what if those choices are not accessible? To connect with our own hearts, to monitor our hearts, to understand our risk. To connect to every heart. We want everyone to have access to the same tools, the same opportunities, to connect people with cardiovascular disease, to create community. Will you use heart to connect?
Close one. Yeah, now I request Dr. P.S. Shankar to address the inaugural. Over to you, Dr. P.S. Shankar. Unmute, sir. Unmute and speak. Unmute. Kindly unmute.
Dr. Muruganathan, Dr. Upendra Kaul, Dr. Satyavan Sharma, Nagaraj, Vivek, Alchatti, Sangram, Murugesh, colleagues and participants. I am happy to associate myself in the program which has the blessings after Dr. Muruganathan. I am happy Dr. Kaul and Dr. Sharma are taking part in the program in which two of our distinguished students, Nagaraj and Vivek, are participating. I am extremely happy about it. The World Heart Federation has created biggest awareness raising program platform for cardiovascular disease through the World Heart Day celebrated every year on 29th September. Its main aim is to reduce the global mortality from non-communicable diseases by 25% by 2025. Cardiovascular disease accounts for nearly half of the NCD deaths, making it the world's #1 killer. World Heart Day provides a perfect platform for the community to unite in the fight against the cardiovascular disease and reduce the global burden. Cardiovascular disease has many causes from smoking, diabetes, high blood pressure, and obesity to air pollution. During the current pandemic of COVID-19, cardiac patients are at risk of developing severe forms of the virus disease. The main aim of celebrating this event is to raise awareness about the cardiovascular disease, its prevention, and its global impact. There is an urgent need to find different and innovative ways to connect people to heart health. Digital health has to be used to improve the awareness and the prevention and the management of the cardiovascular disease globally. In this background, the telehealth has a huge role to play as we use heart to beat CVD, and heart has to be used to connect and use our knowledge, compassion, and influence to have best chance to live heart healthy lives. We have to use the power of digital to connect every heart everywhere. Disconnected hearts are at greater risk of heart disease and stroke due to lack of access to the cardiovascular disease prevention, treatment, and control. The digital tools are to be used in the care of the heart related conditions, and people are to eat a healthy diet, say no to tobacco, and undertake a regular exercise. The digital tools, such as the phone apps, and can help one to be motivated to in this. One has to have regular checkups and take help of the medical professionals at the time of need. Digital networks have the power to connect the patients with the families, friends, patients, doctors, and carers. No one should have feeling of being alone. Hence, it is desirable to use technology to overcome the isolation and the gaps in the care. There is an urgent need to find different and innovative ways to connect people to heart health, and we have to harness the power of digital health. In this background, the theme for the year, Use Heart to Connect, is appropriate. The organizers of this program have drawn the leading luminaries in the country for this particular program. I am happy to associate myself in the inauguration and wish the deliberations all success. Thank you.
Thank you, sir, for your kind words. Now I request Dr. Muruganathan, sir, for your inaugural address.
Thank you, Dr. Sangram Bradar. My dear respected Professor Shankar sir, Dr. Ubendra Kaul, Dr. Satyavan Sharma, Dr. Vivek Jawali, Dr. Nagaraj Desai, Dr. Jayant, and my dear brothers and sisters. It is always a very important organ, heart, not only for medical purpose, even for the romantic purpose or emotional purpose, or even for the purity purpose. You know, I was very happy when Sangram Bradar unknowingly, unintentionally said, hearty welcome. So this theme today is to connect the people with heart. Our heart should connect with our own heart, and heart should connect with other sweetheart, and heart connect to be the heart which is broken also, which damaged heart also. So that is the theme, and we use digital. That's what Dr. Shankar sir was saying elaborately, how digital can be useful for connecting the heart. But today, being the World Heart Day, you should have awareness. See, after all, Vinoba Baba says the one of the purest organ in our body is heart. You know why? Because it always acts 24 hours, 365 minutes, all seconds. Even if they stop for 1 minute, it's a big problem. So without any strike, without any problem, without any corruption or bribe, this heart is functioning throughout their life. That is why it is Vinoba Baba says is the purest organ of the body. And even the romance, they say somebody will stolen the heart, somebody has given the heart, somebody has got two hearts, and they have a broken heart. So always, you know, everything comes around heart. But just think for a minute, are we giving the same importance to the heart? No, we are not giving importance. The heart gives so much to us, but are we taking care of the heart? No, we are burdening the heart with pressure, with a lot of fats, with lot of salts, with lot of assault, with lot of tension. So today we must, study the situation. In what way we can comfort the heart? In what way we can strengthen the heart? One of the way which I'm a passionate person in hypertension, you can kindly control your blood pressure. Also, you also, today if you have not taken the ECG, today you take a ECG for your kith and kin, friends and relatives, check the blood pressure, tell them why heart is important. The heart which is giving you so much of love and affection, in return, you should also start loving the heart by giving support to the heart. So that is the message, the heart, this theme, connect the heart is that's the way you can connect the heart. First of all, you must also love your heart. Only if you love the heart, then you will take care of the heart. Suppose you have somebody whom you love, you take care of them in all ways. So always, you must take care of the heart. At least periodically, you check your heart, whether it is good, whether pressure is good, whether ECG is good. And also we should not get emotion, we should not get tension, how we can make the heart very calm. And with this, I am very happy to, symbolically adorn the medal to all our, citation winners. I have got 4 medals, all different colors. So I'm going to give it to all of them symbolically. And then it's a great honor that we adorn the all the stalwarts of the cardiology, that we are honoring them. By honoring them, we are very proud that, we honored. The last word about the Shankar. You see, I have seen in the whole world, only one profession is not with jealousy. That is the teacher's profession. If a teacher sees some of his students are going beyond his capacity or overtaking him, he'll be very happy. He'll say, my student is the president of India. My student is the president of the Cardiology Society. My student has done hundreds of operations. My student has done this. So though no jealousy at all, only the teacher's profession, there is no jealousy. All the other profession, if you analyze, they'll have some jealousy. So he's overtaking me, he's good. But suppose Shankar says, Nagaraj Desai, Ubendra Goel, he's done. So he's so happy. The moment he says, he's very happy. And the way why Shankar is happy, because he makes others happy, he always, feels young. And every time energetically, enthusiastically he speaks. And whenever he sees his students, his 1 year age will be increasing. Such a good person, Shankar. I'm happy. And I salute all the teachers who taught us cardiology, who taught us medicine, and who, always bless us. With this, I have great pleasure in inaugurating this conference. And now over to Sangram Brother for the proceedings. Thank you very much.
Thank you, sir. Thank you for your kind words of wisdom. Now we move on to the scientific session. I request Dr. Upendra Kaul to deliver his talk. Over to you, Dr. Upendra Kaul, sir. The topic being the cardiogenic shock complicating EMI management in 2021.
A minute, I'll come again. Thank you very much. And I think I'm audible now.
Yes, sir.
It's really an honor for me to be presenting virtually this talk on revascularization strategy in cardiogenic shock following myocardial infarction, acute myocardial infarction. And I'm very grateful and thankful to my friend Dr. Sangram for having given me this opportunity. I wish I was with you sitting in Gulbarga, but maybe some other day. What is cardiogenic shock? Cardiogenic shock represents an inability of the heart to maintain an effective cardiac output, which is commensurate to the metabolic demands of the body. It actually results in deficiency of end organ perfusion. And obviously, it is characterized by all the features of poor perfusion, like tachycardia, hypotension, peripheral vasoconstriction, congestion of both the systemic and pulmonary vascular beds, because of low cardiac output, low perfusion to kidneys, decreased urine output. Patient is mentally usually obtunded. Acute liver or kidney injury occurs because of severe hypoxia because of deficiency of oxygen, and lactic acidosis. The cardiogenic shock, acute myocardial infarction is the most common cause. And when a large portion of myocardium gets involved, the ventricular failure occurs. More than 50 to 60% of myocardium, if it is gone at one stretch, or with a previous myocardial infarction, which was not so big, another infarction comes, there is a tendency for the person to get into cardiogenic shock. One can have mechanical complications of acute myocardial infarction, and Dr. Vivek has operated on many such people. Ventricoseptal rupture, 4%, free wall rupture, which is a catastrophe, 2%, and acute severe mitral regurgitation. Well, the commonest cause of mortality today after acute myocardial infarction is cardiogenic shock. It still complicates 5 to 10% cases. 3/4 of them have multivessel disease, and mortality continues to be high despite improvements in the skills of angioplasty, availability of good stents, and many support systems. It continues to cause a lot of concern. It can be non-infarct related, just to complete the causes. It can be valvular heart disease, terminal, multivalvular disease who has not been treated properly for many years. Acute myocarditis, once again, acute myocarditis, sometimes, they do recover, but about half of them do not. And then we know the Takotsubo disease, where it is, sometimes reversible. It gives quite a bit of shock when the patient comes, but then it completely recovers also. And then serious arrhythmias with heterogeneous treatment strategies. Now, the definition of cardiogenic shock has been a matter of controversy, and not going into all the definitions, but the definition which is accepted is the European Society of Cardiology Heart Failure Guideline. Systolic blood pressure less than 90 millimeters with adequate volume and clinical or lab evidence of signs of hypoperfusion, like cold extremities and oliguria and other things which I already mentioned. Metabolic acidosis, elevated lactate levels, and elevated creatinine. Now, this is the most accepted way, the progression from acute myocardial infarction to cardiogenic shock, and that is the classification by the SCAI, Society of Cardiac Angiography and Interventions. And this is a very logical. Number A is a person at risk. That means a patient who is not currently experiencing any signs of cardiogenic shock, no perfusion, but is at a risk for its development. That means any patient coming with the myocardial infarction. These patients may include those with acute MI, acute or chronic heart failure symptoms. That is, the patient is only at risk. And if we start, salvaging or being careful, he may not proceed further into stage B, C, and D. B means the beginning of cardiogenic shock. That means patient who has clinical evidence of a relative hypotension or tachycardia without hypoperfusion. Some of the signs have come that the pressures have started becoming low, heart rate is fast, but still having urinary output which is adequate and is warm. Stage C is the classical stage. That means at present, the manifestations of hypoperfusion are there, requires intervention like inotropes, vasopressor, sometimes mechanical support, even ECMO, which is available in selected hospitals these days. And beyond volume resuscitation, that means just pushing in fluids does not, salvage, do not increase the pressure or the perfusion. These patients typically present with relative hypotension. And then comes to further grave situation, deteriorating, stage D, a patient that is similar to category C, but is getting worse in spite of whatever you are doing. They have failure to respond to the initial intervention, and this is a very dismal situation. And stage E means extremis, a patient with circulatory collapse, where is refractory cardiac arrests coming, cardiopulmonary resuscitation going on, and being supported by many support systems, And these patients are multiple problems, and beside, bedside laboring and other things, they remain clinically very unstable. And here the mortality is extremely high. Incidence of cardiogenic shock, if you look at, this is from 97 to recent time, you would see that the cardiogenic overall has come down from about 12% to around 8%, means it is still there. What about cardiogenic shock at admissions? Patients coming at admission with cardiogenic shock, they were, from 2%, it has gone up to around 4.55%, indicating that some patients come with a myocardial infarction. They're not in shock, but during the hospitalization, they go into shock because of some complication. And then cardiogenic shock developing during hospitalization. This is cardiogenic shock at admission. That means when the patient comes, he's in shock. And now more patients come with cardiogenic shock because of aggressive management of the early phase of myocardial infarction. They survive, but some of them do not have good perfusion of the coronary arteries and they go into shock. And finally, cardiogenic shock developing during hospitalization. It has significantly come down because of once the patient is admitted, supported, then the patient's chance of going to cardiogenic shock has become lower. Now, mortality of cardiogenic shock, unfortunately, hasn't changed so much. It was about, close to 55 to 60% in 97, and it is still close to 40-45%, indicating that we haven't made tremendous progress. We haven't made tremendous progress in this field. Historical advances in the treatment of cardiogenic shock, you can see that percentage of survival used to be extremely low, 17% in 73. It came to, because of vasopressors and understanding of cardiogenic shock, came up to about 50%. But then you see 97 almost the same, 2016 almost the same. But here with the going in multi-specialty fields and cardiac support systems, mechanical support systems coming in selected institutions, it has improved to about 2000, it's up to about 77%, which is quite gratifying. But unfortunately, this is possible only in selected institutions which have a team of managing cardiogenic shock. What about the role of early revascularization? We know from this paper from Judith Hoffman, early revascularization in acute myocardial infarction is the way to go. You can see that early revascularization usually by percutaneous coronary intervention, but in some cases coronary artery bypass surgery. The 30-day mortality, actually total mortality was not so different, but in the relatively younger people, it was a little better, it was significant. But 6 months mortality, you can see, is clearly better with revascularization as compared to just medical treatment in both the age groups, less than 75 and more than 75. So benefit of revascularization then persisted at 12 months. And when they followed these patients, it also persisted after 6 years. So if you have done early revascularization and looked after the patient, then the 6 months, 12 months mortality, is clearly lower than just medical therapy, howsoever aggressive that medical therapy is. So it became class 1B indication recommendation in the European Society of Cardiology and ACC/AHA guidelines in 2019, which are the recent guidelines. Revascularization in cardiogenic shock delays are always associated with detrimental outcome. Means whatever you have to do it early. You might immediately transfer the person to a tertiary care center because the centers which only thrombolize and have patients with cardiogenic shock, mortality is going to be very high. Fibrinolysis alone therapy has actually no big series. There are some small anecdotal incidences. You do thrombolysis and put the patient on intra-aortic balloon pump, but only those patients who are put on this and then shifted to a higher center would make it. If you just leave them there with this, I don't think they're going to do very well. Now, 70 to 80% of patients had multivessel disease, additional vessels besides the culprit vessels, and multivessel disease patients have significantly higher mortality. Current guidelines recommend early angioplasty or bypass surgery, depending upon the anatomy, depending upon the comfort of the team with the procedure. Very good surgeons like Vivek, will handle it. Some smaller centers may not be able to handle it, and the cardiologist may try to open some vessels that will be better. It all depends upon where the patient is. But one thing is clear, revascularization is the answer. Until recently, it was recommended that do a complete revascularization. But one of the very important landmark studies, the culprit shock study, has changed this view. Now, this is the culprit vessels PCI and staged PCI for multivessel disease. These are the articles of 2017 and 1-year outcome, and by the same group of Thiele, who have the largest experience of this. What are the pros and cons of culprit vessel versus complete revascularization? Well, a purist might argue that if I do complete revascularization, it will lead to better improvement of the jeopardized myocardium because there's other vessels which are involved, and this should lead to improved clinical outcome. But what are the cons for complete revascularization? Well, immediate multi-vessel intervention may lead to more ischemia. You have handled the vessel which was responsible, the culprit vessel, and now you go to vessels which are flowing with 70%, 90% region. While doing it, you produce ischemia, and if you have an occlusion of one of those vessels, you had it. And depends upon the anatomy, but it will be case to case. But in general, that is not the way one would. And you would go on giving them fluids, give them a lot of contrast, and many of them go into acute kidney injury, and that is one of the major problems. So the culprit vessel was better than the complete revascularization in the culprit shock vessel. There was a significant clinical benefit of culprit lesion only strategy with a reduction in the primary endpoint of 30-day mortality or renal replacement therapy. 46% for the culprit vessel only, and angioplasty for all the vessels, 56%. So you can see there's around 10% difference favoring culprit vessel alone, and which is very significant. And this difference was mainly driven by absolute 8.2% reduction in 30-day mortality, 43% versus 51%, very significant. So the benefits were consistent and were sustained at 1 year with an absolute reduction in the mortality. You would see here that the 30-day mortality is still 44%, which is very high, but at the same time, it is lower than if you start fiddling with all the vessels. So routine immediate multivessel PCI in cardiogenic today is class 3B as per the European Society of Cardiology guidelines. Type of revascularization did not influence out of trials. You have to revascularize, and whatever is best, whatever can be done early, depending on the team. About 37.5% in the shock trial underwent bypass surgery. But currently, with more experience with the interventional cardiologists, CABG is being performed in less than 5 to 6% patients in the trials and registries. A trial of culprit lesion only, that PCI, and with stage revascularization, which is recommended, versus immediate bypass surgery, or initially you open the vessel with a balloon angioplasty only, restore perfusion, and subsequently immediately sent to bypass surgery. It has not been done, but many people think that it may be a trial worth doing, in which you give the patient better perfusion with a balloon and take the patient for surgery immediately. But this is worth doing, but I don't think any such study is going on. Access for PCI in cardiogenic shock, well, the guidelines still recommend radial strategy as the default strategy. But then, as you will see in the subsequent parts of my lecture, you are going to balloon pump, you're going to impellas, you're going to so many things. Then possibly it doesn't make much difference because you're anyway puncturing many arteries. In chronic stable angina PCI, we know that radial access is recommended, less bleeding. And the culprit shock, the radial stress access was used only in about 20% of patients as a primary strategy. And the reason is obvious. What about intra-aortic balloon pump for the management of cardiac shock? And this is very important because a large number of our centers have only this. So what is its role? The role, as per the IABP Shock 2 trial, at 1 year, you could see that the 12-month mortality wasn't different. Red line is IABP, blue is, control. Everything done, but without IABP. And the mortality you see is about 46%. So this is dismal. At the same time, I don't think we can generalize the results of a trial because it does give support. We know that it does not, augment the systemic flow tremendously as compared to other devices like mechanical circulatory support by Impella and other things. But certainly it does produce better cardiac output, which is not more than 20%, 30%. So we can't say it is useless, but in general, doing a IABP and thinking that real cardiogenic shock mortality is going to be drastically different, no. But yes, for the shifting of the patient to a higher center and everything, still I think it is as a definite place. And we have anecdotal cases, all of us. I'm sure all the cardiologists sitting here have cases where putting in a balloon did help. So innovations in cardiogenic shock improvements, as you can see, it didn't make any difference, the balloon pump. 1966, 80% mortality, elective PCI with IABP in mid-80s, 60%, shock trial 50%, IABP shock trial 50%. So 46 years from the first IABP used to the first large randomized trial, well, there was not much of a difference between 76 and 2012. How many? 25 and 37 years. So what is the algorithm-based management of cardiogenic shock with MI today? First of all, when a patient comes with acute myocardial infarction, assess the patient and classify shock. If the patient is very stable, immediately revascularize. Revascularization is anyway required. But if the patient has some degree of shock, stabilize the patient. Low BP, malperfusion, consider vasopressors and inotropes. If the patient is hypoxemic, acidotic, consider intubation and ventilation. But immediately send the patient, for revascularization. But if you can diagnose the cause of shock, which is very important, must do an ECMO to rule out mechanical problems like ventricular rupture or a mitral regurgitation. Do a left heart study, do a right heart study, see the cardiac output, see the mass of the ventricle. If there's a mechanical complication, straight away surgical consultation. But if it's a true cardiogenic shock and you have the facility of mechanical circulatory support, go for that. What are the pros and cons of mechanical circulatory support? Factors which favor early mechanical support is, first of all, persistent hemodynamic, electrical, or respiratory instability despite initial measures of inotropes and fluids. If there's a high-risk coronary anatomy, your revascularization is going to be very difficult. And if there's a severe ventricular dysfunction. What are the cautions against early mechanical support? Low level of operator, not a team, institution experience with the device use is not so good. Half-hearted attempts do not work. Ventricular anatomy prohibitive for excess. You can't get an excess. Femorals are blocked. There is peripheral vascular disease. And delay to primary reperfusion therapy if it causes that, you are spending a lot of time in putting in mechanical circulatory support and not able to, reperfuse by angioplasty, is a very grave situation. But revascularization on the culprit lesion is the most important thing. And one has to verify the stability after that before you think of transferring the patient to ICU. Now, mechanical circulatory support can be right ventricular or left ventricular, depending upon predominance. If the cardiogenic shock with predominant left ventricular failure, it is the Impella or IABP. Tandem heart is hardly used these days, but there were some institutions using the tandem heart. If it is cardiogenic shock with predominant RV failure, Impella, the right side. But if it is combined, which is often, then you have to have a Impella left ventricle and right ventricle, both VA ECMO. And ECMO is one of the situations which is if you have that, and it's not only putting the patient on ECMO, but managing the patient on ECMO. The heart team has to manage it because Impella is easier to manage. You put in like a catheter, it's a bigger catheter, but that is totally different than putting the patient on ECMO, which is something like putting a patient on a cardiopulmonary bypass. Now, that is what it is. Refractory respiratory failure, you have to do a VA ECMO, oxygenator. So it's like a complete cardiopulmonary bypass. So without going through further details of mechanical support, I would just give you some take-home messages. Number one, acute myocardial infarction and cardiogenic shock is a complex clinical entity. It remains there. We still have 5 to 10% of infarctions going into cardiogenic shock and continues to be a major cause of death after acute myocardial infarction, despite our improvements in revascularization. Early invasive management by way of revascularization is the best thing. It influences the outcome, progression, and the mortality. We need to optimize the therapy, and we need to have inter-hospital transfer. One should not hesitate. It should not be sitting on vanity. If you don't have all those things, you don't have a team doing it, it's better to shift the patient to a place where there's a team which is manages cardiogenic shock, including providing early mechanical support in those very high-risk patients, as I tried to indicate, patients who are continuing to be in shock despite your vasopressors, have a severe LV dysfunction, have got a very high pulmonary arterial wedge pressure, and have got true hypotension, lactic acidosis. These are the patients. And then approach to multivessel coronary artery disease, including criteria for selected application and timing of multivessel PCI. Do a culprit vessel that time. We have enough data for that. And then other vessels you can do later if you're doing angioplasty, but always a consideration of bypass surgery is important in the situation, and the heart team has to take that decision because the situation is gloomy. Application of targeted temperature management in those patients who come with acute myocardial infarction, cardiogenic shock, and resuscitated cardiac arrest. You have to cool them down, and then optimal temperature management and cooling has to be done to save the brain and save the vital organs. Management strategies always have to take into consideration how to reduce bleeding and vascular complications, which can ruin or wreck a procedure. If you have done very good, done revascularization, patient improving, and then at the end of it, after 4 hours, you know that he is bled like hell from the groin and has, that's a major problem, because anticoagulation management, antiplatelet management has to be done. You can't keep the patient off antiplatelet. Sometimes, drugs like tirofiban have been given because there was a lot of clot in the coronary arteries. So parameter for monitoring the mechanical support device function in institutions which have adept and they are used to mechanical support devices, then you have to monitor them. You have to use them properly. And if the patient has gone on, what you call as the ECMO, is a very separate team has to manage it, because ECMO management is difficult. And then interplay with the vasoactive drugs, therapies are important. Even if the patient has gone on an Impella ECMO and is recovering, then you have to wean them off. And weaning them off, once again, IABP comes in, because it does give that small amount of support, and you can keep that intra-aortic balloon pump for days together. You can't keep Impella for days together. You can't keep ECMO for long periods. So one has to learn managing this, which is art as well as science, and a team work is the most important thing. Thank you very much.
Thank you, sir, for your excellent deliberation. Kindly stay connected. We will take the questions.
Yeah, I just want to go to unshare my slide. I can't see that icon.
Okay.
Stop.
Yeah, that's there. Now I can stop share. Okay,
Yes,
thank
sir.
you.
Thank you.
Thank you, sir. Thank you once again. Now I request Dr. Nagaraj Desai, sir, to take over the floor for the panel discussion. I request Dr. Satyavan Sharma and Dr. Vivek Javadi, sir, to join. And also happy to invite Dr. Jayant Antani, sir. Are you audible? Welcome, Dr. Jayant Antani, sir.
Thank you.
Yeah, kindly unmute and speak, sir. Kindly unmute. Yeah.
Yeah, well, thank you, thank you.
Thank you, sir.
I'm enjoying the talks.
Okay, sir.
Great. Okay.
Over to Dr. Desai, sir.
Thank you, Dr. Sangram Biradar and Professor P.S. Shankar and Dr. Muruganathan. And of course, my teacher as well, Professor Upendra Kaul, from whom I learned ABC of cardiology when he was part of PGI staff. Indeed, when he started, his talk, it really reminded me of his own presentations in several fora that I've heard from him. And all the questions that I was ready with, already he has answered many of them in a very succinct manner and in a very up-to-date manner. Indeed, our deliberations in the next about half an hour is more a recollection and a reinterpretation of the concepts that he has propounded based on evidence that has been provided for the last several decades now. As you see, cardiogenic shock is one condition where the prognosis is so guarded, and as the pendulum shifts to the grade E, the outcomes are going to be worse off. In other words, it is a kind of a situation where the dynamics of the heart and physiology of the body keeps evolving over several minutes to hours time, and physician has an important task to deliver the care of these patients. Now, having said this, that we know that cardiogenic shock has a poor prognosis, and many of these patients are distributed across the country, not only from metro, but also in Mofussil towns and Talika headquarters, and also several small towns. Fortunately, we have quite a few cath labs coming across in the country, and in Karnataka also is well served. And I'm sure across the country it is happening now. Now, in case we have to improve the prognosis, the patient has to come into the hospital system as quickly as possible. Then, what is the current concept about the so-called the door to balloon time, shifting from there to symptoms to the balloon time? Let me take help of Dr. Satyavan Sharma to elaborate this concept, because Dr. Kaul was mentioning about the stage A to stage E, and who are these patients who are in stage A? Dr. Satyavan Sharma, sir, in fact, I have also heard him several decades now. Have learned quite a few tips from him also. Let's hear him talking about it. Dr. Sharma, please.
Good evening, everybody, and good evening, Nagraj. I think the question which you are posing is that what about the concept of door to balloon time, right?
Versus the chest pain to balloon time, because the symptom onset versus the balloon time is more important than the door to balloon time. That's what I was trying to make sure that we have clarity on that issue.
Absolutely. Let me begin the answer in a little different way. Say, as far as the door to balloon time is concerned, this begins when the patient comes to the casualty, to our bringing him to the cath lab and our doing the angiography and putting the balloon. those times have started shortening in almost all our institutions because of each and every institute making its own system and trying to expedite the procedure of palmism once the patient is inside the hospital. But I think what continues to remain the challenge, not only in our country or in our states, but all over the world, is from the patient starting to have symptoms to patient reaching the hospital. And I think that is a crucial time when the patient recognizes that he is getting a acute coronary episode or acute myocardial infarction, and patient trying to reach the hospital as early as possible. So I think in our society and in our cities, still there is a lot of time which gets wasted into a patient's recognizing, and then he's trying to reach to a lab where there are facilities of primary PCI. First, the person gets symptoms, he will contact his GP, he will try to reach to a small center. So I think that is where I think still there is a lot of patient education, public education, which is required. And I think still we are getting patients where the presentation, the patients experiencing symptoms to reaching to the cath lab competent center is quite long. So, these are completely two different things. And I think we need to shorten this period by more and more patient, public, and doctor education.
Thank you so much. In fact, it is an important consideration when we manage the patients with acute coronary syndrome. Having said that, can we predict shock in a given patient? Can we, though Dr. Kaul mentioned it in his presentation, can we revisit that statement by him? Can we predict a cardiogenic shock in a given patient as he comes into the hospital? Because we know clearly if the patient blood pressure is low, we are able to diagnose. But who are these patients as we are getting these patients into the casualty, where such a patient may go into the cardiogenic shock in the next about 15 minutes or half an hour or 45 minutes or 1 hour? What is your take on that? How do you advise your fellows?
Yeah, I think it's a very important question, and that is the stage when we can, turn the tables. Now, a patient coming with a large anterior myocardial infarction, and if you look at that sky pyramid going into, say, stage B, means the blood pressures are borderline, not a hypertensive, but the blood pressure is 100, or if he was a hypertensive of 140, 150, has come down to 110, heart rate is, 90, 100, or very slow, old anterior infarction, now coming with the inferior infarction. So that is the stage if which, we have to first of all see that he is not hypovolemic. And at the same time, do something so that hypotension is not aggravated. Giving them very high dose of intravenous beta blocker at that stage, you get into problem. On those acute MI beta blocker trials, this is one of the cautions. Beta blockers are extremely useful, extremely good, but you have to use them judiciously. A patient coming with hypertension, acute MI, sinus tachycardia, yes. But a patient coming with borderline pressures and tachycardia, no. Because the last straw would be you bring down his pressure to 80, and then unnecessary nitroglycerin use. You still, put him on nitroglycerin, vasodilator. Pressure maintenance is extremely important, and that is the thing which in the first half hour of 40 minutes, which you talked about, is extremely important. And, small dose of vasopressors after giving fluid may prevent him going into stage C. Once the patient goes into stage C and the patient goes into, all kinds of things, then as I told you, then things starts deteriorating and they don't, really.
Yeah. In fact, as you rightly mentioned, the pulse rate, the heart rate, the kind of blood pressure, measurement, or important aspects of the assessment of the patient. Do you have this opinion whether it is STEMI or NSTEMI? Same approach, the blood pressure, numbers are in the borderline range. Should we treat NSTEMI also as a kind of cardiogenic shock in case the blood pressures are borderline? What's your opinion on that?
Absolutely, absolutely. Although, it's more common in ST elevation MI, but NSTEMI, they can present as a left main disease, can come with 6-7 millimeters ST depression, sometimes a elevated ST segment in AVR lead, or that could be one of the situations. But NST MI should not be taken lightly. If they have ventricular, it's basically ventricular dysfunction which matters. How much of the ventricle is involved, that matters. If you have a severe LV dysfunction, lactic acidosis, all the features of poor perfusion, it is a bad situation.
Yeah, indeed. Just to kind of buttress that argument that NSTEMI may be an STEMI for a left circumflex lesion, where it is really due to closure of left circumflex, which also can manifest in the ECG as NSTEMI, one should be careful about. Now, in the sense you mentioned about shock developing during the hospitalized, period versus patient coming with the cardiogenic shock. You did mention the outcomes of such patients who develop cardiogenic shock as they are into the hospital setting. Now, how exactly this happens really, despite our treatments? What could be underlying pathologies or pathophysiologies which may be working? Yeah, go ahead.
I think the ongoing ischemia and delay in revascularization sometimes cost. Patient is hypotensive, let us wait on, let us bring the pressure, stabilize, and then take him. Patient coming at 10 o'clock at night or 11 o'clock at night, okay, let us stabilize, I'll come in the morning and do it. Those are the things which do not work in presence of ongoing ischemia and missing a mechanical complication. I have myself seen a patient coming with acute inferior lateral MI and no echo done, take the patient to, cath lab, occluded big circumflex, opened it, other vessels normal, sent to CCU, patient not improving. You see, okay, he'll be all right, he will be all right, it may take some time. But then next day you see, say, acute mitral ring agitation, what the hell? It's not going to make it. You have to, do something to that. And fortunately, few of those patients, aggressive surgeons worked on it and salvaged, but these are some of the blunders.
Yeah, it's an important statement that you made, that the thorough evaluation by all the modalities, especially imaging techniques that we have now very easily available in the CCUs and, in the casualty, one should make use of it. And of course, the proper interpretation can be definitely helpful. You did mention that thrombolysis may not be very ideal. Many a time, we are taught very aggressively about this pharmacoinvasive management. You did mention about the transfer of these patients to the, cath lab setting area. What is your take? For example, a Mofussil area patient comes with a borderline blood pressure. Should they be worried about giving thrombolysis at all? In case thrombolysis has to be given, what is thrombolysis, drug of choice for you?
Obviously, thrombolysis drug of choice in such situation will not be streptokinase, it will be tenecteplase, which can be given as a bolus. Bolus does not produce hypotension. Streptokinase, if you give, hypotension is common. And these patients, typically these cardiogenic shock patients, have a very large thrombus burden. And that is the reason thrombolysis doesn't work. Coronary arteries are full of clots, and you're not going to, do wonders in that situation. But if you don't have anything else and you don't know what is going on, you do thrombolyze. The lucky ones who don't have that much of a clot there will help. And then use vasopressors, use the pressure, and if the pressures are not coming up, try and shift them as early as possible. These days roads are better, ambulances are much better than what it was 20 years, 10 years back. Shift them to a hospital while, cath lab is there. The Fossil Hospital won't have intra-aortic balloon pump, and there's no point of having a IABP when you cannot introduce it properly after giving thrombolysis, do a puncture in the artery and produce a huge hematoma. Gone, isn't it?
That's
All
right.
of us have seen these disasters.
Okay, now I have a question for you. There is a term called systems of care for STEMI. I'm sure Satyavan Sharma also can contribute to this discussion. What is your take on the system of care for STEMI management and also COG and wheel management, COG and rather center management, wherein there is collaboration between the small centers and the central center, where they offer the catheterization. Should it be a model that should be working for? Because Tamil Nadu STEMI program, it has worked very well. What's your opinion on that? Dr. Kaul and also Dr. Sharma, please.
Yes, this hub and spoke program has shown a lot of, good things. And Thomas Alexander and Ajit Mulasri and all their colleagues should be congratulated for giving this concept that, patients who are closer to the hub go there straight, 30 minutes or 45 minutes. Patients who are close to the spokes, don't waste time, go to the hub, thrombolize, go to the hub then. And that is, if you have a program like this, depending on the time, because as all of us know, time is very, very important in these situations. Early revascularization, if you don't have PCI, thrombolize and send them within 24 hours, and large number of them, 50 to 60% of them get perfused, isn't it? Even with streptokinase, 40% used to get perfused. With TNK and other things, you get perfusion in up to 60% of patients. Failed PCIU, failed thrombolysis, you should understand. Don't waste time. ST continuing to be high, pain continuing to be there. Just send the patient to the hub.
Yeah, that's important. Do you have any opinion on this particular aspect, Dr. Satyavan Sharma?
Actually, this is an excellent concept, and this has been evolving in our country and of course in some other countries, and even in India, there is the same model of hub and spoke has been quite prevalent in Goa, and recently in Indian Heart Journal there was a paper from Goa experiment. So I think this is a very, very nice system that if you don't have access to cardiac catheterization laboratory, give thrombolysis quickly and send the patient for pharmacoinvasive. In fact, this sort of arrangement, I will say if not as a program, but as an arrangement, this is going on in our country. Say like in Mumbai, I am aware of particular suburbs, where there are many small intensive care units. The patient reaches there, they immediately thrombolize the patient with tenecteplase and say they have their colleague, who is having a lab up in 10 kilometers or 50 kilometers, and then they send it to him for doing the either pharmacoinvasive, or if the patient reaches to them very quickly for doing a primary PCI. So as a concept, yes, this is excellent concept. As an organization, whether your state can take it or your city or your institution, I think this should be promoted more and more.
Sure, definitely. I mean, there is something like outside the hospital, there is a care system, like what we mentioned about the spoke and hub model. There is also an inside the hospital, there should be a system of care, as Dr. Kaul was mentioning about the heart care team for extending the benefit to the patient beyond interventional cardiologist. Casualty system should be geared up. The ICU system should be geared up. Administrative delays should be addressed. Several ways in which the STEMI care have been addressed, and patients like cardiogenic shock, who have cardiogenic shock, immensely benefit for such programs. Indeed, when we shift the patient away into the, into the hub and also manage these patients very effectively throughout the week, including the weekends and during the night, as Dr. Kaul was mentioning, that is very, very helpful. Now, he did mention about the radial approach versus the femoral approach. What is your opinion on that, Dr. Sharma?
Say that if a patient is coming to you in cardiogenic shock, say whether patient comes to you during acute MI or during acute coronary syndrome, then there are more and more procedures now being done by radial. But if a patient is coming to you already with signs of hypoperfusion, I think I'll prefer a femoral approach so that all the support devices and these can be utilized.
Thank you. Thank you. In fact, as Dr. Kaul was mentioning about the need for mechanical circulatory support or circulatory support in some individuals at least. Let's hear Dr. Vivek Javli now as to what is his approach to the usage of these support system in his own care, and dilate upon with some instances of his own practice. Dr. Vivek, please. Dr. Vivek.
In an acute MI situation, surgeon's role is limited except for treating the mechanical complications, VSR and MR. And if the cardiologists in the CCU require us for the mechanical support. What we have done in our setup is we have a crack ECMO team, which also doubles as a good IABP team. We have been observing the complication rate of IABP between CCU and surgical ICU quite significant. A sheathless insertion, very low trigger for IABP rather than putting it late. At same way about ECMO, if you think the patient is sinking, the all parameters are going worse, ECMO should be put much earlier than later. This is a lesson we learned during the IABP period. Now we are relearning the same lesson in the ECMO. The hospitals, most of the majority of big hospitals, which have got all kind of modern facilities, must have a cracked ECMO team, which should be capable of going to a nursing home, going to a peripheral place with the ECMO in a van, screwed up on the floor, and can be able to resuscitate a patient who has been resuscitated from cardiac arrest, put on ECMO and bring it back. So most of the other things are talked about, but are not available widely. So it's just IABP and ECMO. And I would also at the same time like to take this opportunity to talk on mechanical complication. I have been quite troubled that most of the cardiologists diagnose quite early, but prefer to wait and see whether they could improve the patient. If there is a ventricular septal rupture, or if there is a papillary muscle rupture, there is actually nothing like waiting. Because if you wait and if the acidosis starts, then most of the time we end up operating very late, and then there is a natural selection. Those who are supposed to die will die. Some good juicy patients will come to us and I'll give you zero mortality. But that is not the thing. There has to be a proper strategy in any given hospital along with the bureaucracy, cardiologist and cardiac surgeon. A patient comes in, he's brewing a cardiogenic shock or showing signs of going down. First thing is do an echo. Echo is available at every taluka place today. Echo will tell you there's a VSR or not. Echo will tell you there's a papillary muscle rupture or not. If such a thing is there, there has to be an immediate alarm raised to the surgical team. The surgical team, we have a very clear-cut understanding with the administration that there's no bureaucracy involved in such cases. Our team goes and this patient, families explained briefly and they're brought immediately to the theater. This patient from the CCU goes directly to the theater. In the shortest possible time, we go on cardiopulmonary bypass. Once we have gone on cardiopulmonary bypass and vented the heart, then we are on top of the situation, there's no problem. If in time, the ventricular septal rupture is closed or total septal closure is done, or the mitral valve replacement is done, all these procedures are extremely standard. Now, the junior most person in my team is able to operate an 86-year-old man with a septal rupture without waiting for anybody. The how do you suture, what layers of suture, what patch, everything is standard. So the mortality then you can dream of less than 5%. If you don't do this, then you get into problem. And both for IABP and ECMO, trigger should be low. IABP always sheathless and earlier than later. I want to add one more small point about this primary angioplasties. Many times the door to balloon time is delayed because there are some cantankerous relatives who will go on asking questions and are not satisfied. Our trick for that has been in a vernacular language with some amount of animations. We have created brisk, short, explanatory, WhatsAppable videos. And the moment such a person comes and decision is not taken in the casualty, we tell them, we WhatsApp them this video, ask them to quickly send the video to the whole family if necessary, create a family WhatsApp group. These videos make them agree very fast, and then rest is the different story.
Excellent point, Dr. Vivek. As usual, a very practical point in terms of educating the patient's relatives, especially, and of course, involve them and enroll them into the management
And
strategy.
with the administration, no finance clearance for this small group of patients. All that is later on. Many
Excellent.
times they may have to waive. We will adjust with other patients. That is why many major institutions in our city and in our state, we see that there is an unnecessary delay. And this is because no clear-cut understanding with bureaucracy that you take this financial hit, we will do you good somewhere else.
Yeah, sure. That's what I was mentioning about the system of care of STEMI in the hospital system will have to be individualized, and the administration will have to be enrolled into what you want to offer to the patient, especially in such dire situations. Now, having heard this, Dr. Kaul, when would you like to bring in your surgical colleague into the consultation for such of these patients who have cardiogenic shock? Will you do it, say, on day one for a review, or would you like to wait for 24 hours? What's your take on that?
Well, left to me, having seen disasters and having seen a serious issue, I would like to show the patient to the cardiac surgeon, as soon as I know this is cardiogenic shock. And I will never stand on this kind of a prestige. Why? Unfortunately, some of our younger colleagues have become, I don't know, daredevils. They think that they can handle everything. I'm not generalizing the statement anyway. But this is a tendency, I'm sure Bangalore also should be having some of it, is that they would, hide from the surgeon. They would not tell the full truth to the surgeon. That is not the way. Fine. Surgeons, physicians, cardiologists and cardiac surgeon have to work together in these situations. A single vessel disease, Vivek is not going to go and get a lima graft now. There's better way. Similarly, patients with multivessel disease and hypotension and all that, even if Vivek would say that, you go ahead and do this first and then we'll see. But then it should be in the knowledge of each other in an institution where there are both good teams. Well, if there's a team where there's 10 cardiologists and 1 cardiac surgeon, there are such hospitals also, it will be the other way around. So it is a case-to-case basis, but I think the best way to salvage a patient is to have what we call as a heart team. We hardly talk about heart team. In our trials, we say heart team, but I never go to them.
Yes, I think that was a strong SOP by the organization, sitting together with the cardiology and cardiac surgery team, the way forward. I'm sure Dr. Satyavan Sharma may have his point from Bombay and Mumbai rather, and what is his approach and what is his institutional approach on this. Dr. Sharma, please.
Nagraj, actually the institutional approaches, I'm sure, in all big cities are so extremely variable,
Yes.
that, no city is a really a homogeneous unit. And, more, what I should call as more and more private institutions, the heart team concept is, it is there also and it is not there also. And with those institutes where there is a lot of financial involvement and where institutions don't support the finances, the problems are completely of different type. Just remaining on the point which Upender was and Javli was mentioning about bringing the surgeons, this thing. Actually, many of us bring our surgical colleagues into picture quite quickly. And even, if there is a patient who is having an impending shock, you took him for doing a PCI, and the patient turned out to be having a multivessel disease with a very unfavorable anatomy. It is sometimes a good idea just to do a POBA and send the patient for surgery early, rather than doing some heroics, and then, once the patient starts worsening, to consider surgery. So I think involving the surgeons for mechanical complications without delay And even in those patients where there is a hemodynamic instability setting in with unfavorable anatomy, I think it is good to have them show them the angio quickly and plan out your steps.
Thank you so much. I'm sure all the seniors and the eminent people think the same way. And it is an important concept that we have to kind of inculcate into our care of patients with ACS. Of course, patients with STEMI and patients with cardiogenic shock, especially who have multivessel disease and mechanical complications to deal with. Now, I'm almost coming to the end of this panel discussion. In case you have some messages for the societies and for the government and to the individual physicians, what is your message, Dr. Kaul, as to how you would like to manage these acute coronary syndrome in the future? Anything that has not been said so far that you would like to add on at this stage? Dr. Kaul, please.
I think many things have been said, but at the same time, saving a patient of myocardial infarction is the responsibility of the community, is the responsibility of all the doctors, hospitals together. And in this situation, they should not be sitting on this thing that I'm talking of Delhi. Say I'm sitting in Greater Kailash, but my doctor is sitting in Noida. I have to go to him only. I'm sure in Bangalore also this happens. The family wasting time. So I think public health education programs every now and then it has to be repeated and repeated and repeated that time is muscle. Take the person to the
Nearest.
closest place. Chest pain, get it bloody ECG done. ECG not being done for, I'm not going to get an ECG done. It might be a heart attack and all that. So ECG to be done. Time, as you rightly said, the time between chest pain and ECG has to be minimized. People say it should be within minutes, within 15 minutes. And from there it starts acute MI revascularization. If we have this philosophy, the topic of today, cardiogenic shock, much less number of people will go into cardiogenic shock. Still, they will go. There will be some multivessel disease and all that, but that will reduce it. And then the government also putting in, like I think in Karnataka government and government from Andhra Pradesh and others have made some programs for this. Put in some money in insurance, and doesn't matter. You go ahead and we'll do it. You don't have to. Now that problem is sorted out. All stents are almost the same. Otherwise, previously, which stent to be used, waste bloody 1 hour for that. I will go and ask, I want a expensive stent. So I think organization of and as Vivek was saying that in his hospital, he has kept it, and I know we have worked for some time in the same institutions, that, acute MI patient don't have to go to that counseling bloody person there who is going to say first pay this and then you go this. It's happening. It's happening. So it is the doctors who have to take the responsibility. I always used to, from my first Bhadra hospital stint of 97 when I left AIIMS, standing instruction, acute MI comes, straight goes to cath lab, put the bill on me, care of me. And I must say that hardly any patient, 1 or 2 patients died. Obviously, it's very difficult for a poor person who has died and you have put in balloon pump and this thing and that. You can have that pool, you can have some pool of money. So patient, it's our responsibility, the hospital's responsibility to handle these patients, and doctors dictate the hospitals if they want.
Excellent point, Professor Kaul, that you pointed out. Doctors also will have to be kind of enrolled into the business part of managing the patient and the care of the patient. All doctors should have their MBA degrees so that they understand the finances of the hospital and care of the hospital and systems of care. Dr. Satyavan, do you have any comment or a message for the audience at this stage?
Actually, Upender did mention all the points very precisely. I'll just add a line, many times our own patients who are under our care and, when they get the symptoms like an acute coronary syndrome, I've started telling them, that rather than wasting your time in reaching to me, go to the nearest place where there is a lab and even identify them, one for them, and tell them that you just get in there, let everything will be started and I'll speak with your doctor. So I think, and these days, I think digital technologies have made something easier also. Many times patients get an ECG and they immediately send it to you on your WhatsApp. So I think that we all have started promoting that, otherwise
Excellent. Yes.
in earlier years, it will take few hours for them to get an ECG. And now even with the Apple Watch, just
Yes,
a few
that's
weeks
right.
back, a patient sent me a lead which was suspiciously looking like an ST elevation, and then he quickly got his ECG at a center and management could be facilitated. So I think these are the small things, but again, the
Important.
patient education, public awareness, still we need to do a lot.
Thank you so much. Dr. Javli, closing comments from your side.
I had one more point to say from my understanding of Karnataka, that in every state, the government insurance schemes, micro schemes are maturing, whether it's our Suvarna Arogya Suraksha or the others. The liberal support for thrombolysis in the Mofussil and peripheral areas is still lacking. And I think that is one area where we have to struggle. We have to pressurize the government and make them understand that all the Mofussil areas, which are a little away from the cath labs, thrombolysis is a golden tool. And today, even whatever they say, the support is really not massive enough. And that is another missing piece of the jigsaw puzzle.
Thank you, Dr. Vivek. Friends, faculty, I'm sure you enjoyed listening to the questions and comments and interactions that we had. And we want to make sure that the least number of patients develop cardiogenic shock in a patient who has an acute coronary syndrome. And acute coronary syndromes are reduced to a great extent by avoiding the development of atherosclerosis. And it doesn't happen with just about learning about the angioplasties and surgeries. It has to be some kind of a primary prevention program and even primordial prevention program for our communities. And I'm sure while we appreciate, deeply appreciate and love the talks of Dr. Upendra Kaul, the important message he also carried was it is the systems of care, it is the enrollment of the government and societies which deliver the patient of all the miseries that they have with ischemic heart disease, an important ailment that we have in the modern times. With those remarks, may I request Dr. Sangram to take over from here and conduct the rest of the proceedings. I enjoyed talking to you. Yeah.
Before you give over to Sangram, I think we must put on record our appreciation of enthusiasm of Sangram Biradar, consistently having such good quality meetings.
Excellent. I'm glad that you said that. I was about to say that before. Anyway, thank you so much, Dr. Vivek. And
I fully endorse what Vivek said. The enthusiasm of Sangram is unparalleled.
That's right.
Sure, I agree.
Thank
Thank you,
you.
sir. Thank you. Dr. Antani, sir, your comments?
I think I enjoyed it. Thorough, absolute, brilliant exposition of problem at hand. And no question that, let me congratulate you also for having organized this. Beautiful.
Thank you.
Thank you, sir. It is all the blessings of all the legends which you have left in the past, Dr. Antani, Dr. Muralidhar, Dr. P.A. Shankar for this place. So lastly, since there are no questions in the chat box, that speaks that all the powerful talk which was delivered was crystal clear. The discussion was crystal clear. There were no questions at all. Everything was understanding clearly. So finally, we conclude by saying the vote of thanks. I thank Professor Upendra Kaul and Dr. Nagaraj Desai for beautifully moderating the session, Dr. Satyavan Sharma and Dr. Vivek Javli to be the part of the panelists for making this a wonderful interactive session, because nowadays all people, nobody wants to hear the talks. Everybody wants to have a discussion, clarify the doubts, take home the carry on messages. Thank you one and all for being the part of the program and making the program a wonderful interactive session. Thank you, Dr. Kaul, sir. Thank you, Dr. Vivek Javli. Thank you, Dr.
Thank you.
Nagaraj Desai. Thank you, Dr. Satyavan Sharma. Thank you, Dr. Antani, sir.
Thank you. Thank you very much.
Lastly,
Thank you all.
yeah.
Thank you.
Take care. Thank you. Thank you, sir.
Thank you,
Good night.
Sangram. Thank you.
Thank you, sir. Thank you. Sir.
Thank you, Dr. Sharma ji, Dr. Kaul, Dr.
Bye-bye.
Shankar sir,
Nagraj.
Dr. Antani. Yeah, thank you.
Nice,
Thank
nice,
Thank
nice
you.
to be
Thank
able
you.
to
Thank you,
interact
Satyawal.
with
Thank you.
Upinder after a long time.
I know. Sangram, thanks.
Thanks, sir. Lastly, I thank the audience who have attended from all over the country, making it a pan-India program. I once again thank all the audience for being the part of the program. Thank you one and all. Stay safe. Take care. Goodbye. Good night. Namaste.